Welcome to AETCM, the emergency medicine channel. Today we are going to discuss a case about a 52-year-old female who was brought to our ER with complaints of outside diagnosed left gangliocapsular infarct. She's a known case of HIV, sir.
Okay.
So on initial arrival, on initial 10-second assessment, she was drowsy but arousable. Coming to the airway, it was appearing patent and there was no pooling of secretion. In the breathing, air entry was bilaterally equal with respiratory rate of 20 per minute with saturation of 98% maintaining in room air. In the circulation, she was having a BP of 100/70 mmHg with pulse rate of 78 per minute and all peripheral pulses were palpable. In disability wise, her GCS was E4V3M6 and whereas pupils left side was 2.5 mm and right side was 2 mm but which was not reacting to the light.
Okay.
In exposure, temperature
what
was...
What are the cause for anisocoria? Is it anisocoria? Even if it is a slight difference, it is anisocoria.
Bleed, sir, IC bleed, intracranial bleed.
Which all cranial nerves are involved?
3, 4, 6.
3, 4, 6. That is too much.
Optic nerve, sir. Optic nerve.
3, 2 and 3. Okay. Or in the center.
Center.
Okay.
Then further examination, systemic examination, her CNS examination, GCS was E4V3M6 with pupil 2.5 mm on the left side and 2 mm on right, not reacting to night. In the extraocular movements was abnormal. Left and right lateral rectus was normal, whereas other movements were minimal to absent. And there was bidirectional nystagmus present.
Okay.
And in the power...
Bidirectional vertical or horizontal?
Sir, it was vertical.
Where will you get that?
Horizontal, sir.
Horizontal. Where will you get that? Horizontal bidirectional nystagmus. But that means both are cerebral. It's a cerebellitis. Okay, inflammation of whole cerebellum. Okay, not a unilateral problem.
And power, her left upper limb or lower limb was having power. Left upper limb was having a power of 5/5 with the lower limb having 3/5, and right upper limb and lower limb was having 0/5 power.
Okay.
Plantar right was mute and left was flexor. Sir.
Okay. So what do you think? What type of stroke it is? What type of stroke it is? Is it a simple stroke or what type of stroke?
Multiple stroke.
Multifocal stroke. Multiple foci is there. What is the common cause for this type of strokes? Embolism. Embolism from the heart. Okay, then other than that?
Vasculitis.
So there are two important reasons. One is emboli from the heart. Other one is vasculitis. In HIV patients, these type of vasculitis are very common. Okay.
So, sir,
vasculitis can be an inflammatory vasculitis or an infective vasculitis. Both are possible.
Further examination, chest was showing bilateral lower zone crepes. But air entry was bilaterally equal and CVS and GAT examination was normal, sir. We further sent routine blood investigation, sir.
What do you think that crepitation is due to?
Maybe as the patient was an HIV patient, patient can have supra-adult infections.
What infection?
Like TB, pneumocystis pneumonia.
How do you differentiate TB and PCP pneumonia in retrovirus patients? Clinically. How do you differentiate? Pulmonologist. How do you differentiate? TB is less symptomatic, PCP is more symptomatic. Less signs in PCP, more symptoms in PCP because they will be having severe breathlessness, hypoxemia, but clinically you may not see anything. X-ray also sometimes you may not see anything, initial phase. But TB is not like that. X-ray shows a lot of findings. Patient can have minimal symptoms. They may not have this much breathlessness. Okay, so there is a major difference.
Further coming to the second...
Only two differential diagnoses for crepitations.
Sir, a patient, HIV patient can have non-infective causes also, sir.
Fungus is very common. Fungal pneumonia is very common. Then
COPD bronchial asthma can also occur in HIV patients, sir. Then hypersensitivity reaction, cardiac failure, ischemic cardiomyopathy.
Cardiomyopathies are very common. Cardiac failure is common.
Then renal.
Creatinine is normal or normal. Okay. Okay, continue.
Further, coming to the secondary survey, she was a known case of past history of SAH with ruptured aneurysm started post coiling, and his own outside diagnosed pulmonary TB started on ATT, empirical ATT, sir. And on the outside, which was she was having the weakness as diagnosed with left ganglion capsular infection. So the history is like she was having a history of acute onset.
TB produce vasculitis?
Yes.
Yes, TB is one of the common TB, syphilis. All these things can produce vasculitis, especially in HIV patients.
So she was having the history of acute onset of right-sided upper and lower limb weakness with slurring of speech and angle of mouth deviation since the past 2 days. She was admitted in the outside hospital where CT was taken, which showed left gangliocapsular infect, and was on treatment there. Further, she had a progressive worsening of lethargy and anorexia, and she was referred to a hospital for the further management. Medicines on admissions, she was having ecospirin, atorvastatin, cilnidipine with carvedilol, and Septran DS and Spegra also she was taking.
Spegra
is the triple drug regimen for HIV, which contains tenofovir, emtricitabine, and dolutegravir. Sir, further we sent the routine investigations, which was showing a total count of 4,500 with the platelet count of 2,42,000, and SGOT-PT was on the slightly elevated side, 155 and 160, sir. Here CRP initially was 50, sir, and further we did a repeat MRI, sir. Repeat MRI was showing multiple vasculitic infects like multifocal hyperintensities in suggestive of different age, acute to subacute. Mostly they were suspecting vasculitic infects, sir. So patient was also started with treatment for the LRTA like picture, and she was started on initially injection colibitol, sir.
Colibitol is
sulfamethoxazine.
Okay.
Sulfa drug. Sulfa drug, sir. And then later she was also complaining of blaring of vision, sir. An ophthalmologic evaluation was done, which was showing perivascular cotton wool like spots, and we sent a cytomegalovirus PCR also, which came out to be positive, suggestive of CMV retinitis, sir. And further we sent the other routine investigation, which were within normal limits, sir. And for the retinitis, we started her on initially.
What is the first diagnosis? How do you manage this case in emergency room?
So
first, what is the initial impression? CMV is a chronic problem. It can take time and treat.
So right now the patient came with a outside diagnosed stroke, multiple vasculitic infect.
Okay. Is it vasculitis due to problem like cholesterol or platelet induced thrombus or something else?
Mostly it will be caused by the HIV induced or TB induced vasculitic infect, sir.
Have you done LP?
LP we had done, sir.
What is the finding?
So we had done the LP, sir. LP was showing a total count of 15 with the CSF glucose of 51 and CSF protein of 199.
So what do you think?
So this can be a viral picture or counts are on the lower. Protein is elevated, sir. Elevated. Glucose is low. That will be bacterial.
So it is bacteria or TB is a bacteria. Fungus can produce same picture. Okay, it is not. It cannot be viral because it's acute. It's a chronic problem. Multiple infarcts are there in different areas, different age. Multiple infarcts are there. So it cannot be viral. It has to be either because of
partially
TB
treated
or a chronic infection like fungus. Okay, so you have to rule out all these things. What else is there in CSF finding? Culture, anything is positive?
CSF culture was negative,
India
sir.
ink preparation.
Sir?
India ink preparation.
India ink was negative, sir.
Okay.
Then we also did AFB smear, which came out to be negative.
Okay.
Smear fungal was negative.
Okay.
And CSF ADA was done, sir. 2.6.
Okay.
Then
Is it CSF ADA is significant or not significant?
non-significant.
It is not a significant test at all in CSF. It is a significant test in
Pleural.
pleural fluid. Okay, that's all. Okay.
Then we also did genus by TB also, which was also negative. Then other investigation including
What is expert?
CB9.
What is it? Where will you use it?
Sputum.
Sputum positive or negative, CB9 can be positive. It is mainly used for rifampicin and INH resistance. Okay, to know, it gives a faster report of TB positivity and it gives a resisting report also. Okay, if it is negative means mostly it is negative. Okay.
So we also did the CSF cytology also, whereas no atypical cells were seen, sir. Then cryptococcal antigen was negative.
Okay.
And smear also for the same cryptococcus was negative, sir.
Culture?
Culture was negative, sir.
Was this patient treated with antibiotic cells?
Outside they were treating the patient for stroke, whereas outside also she was initially started on antibiotic.
Okay. So partially treated
Bacterial meningitis
can
can
same problem. Okay. Oh, how do you treat this patient?
So she should be she was already on the spegra.
What is the X-ray finding?
X-ray was showing bilateral lower zone minimal infiltrate, sir.
Okay. The requirement of oxygen.
Oxygen requirement was there.
ABG.
ABG was showing slightly acidotic picture, sir. 7.35 with PCO2 of 50, sir.
Okay. How do you manage all these things? You keep in mind. This is a retrovirus patient. She's having bilateral cryptation, bilateral infiltration. Previously partially treated tuberculosis, meningitis, multiple infarcts in the brain. Sodium?
Sodium 122, sir.
That is low. Urine sodium?
Urine sodium 119, 114.
So that means
SIADs.
SIADs is there. So all these things, how do you manage in emergency room? First preference is for what? Is airway, breathing, circulation is okay? Is it okay?
Initially it was okay. A little O2 support was needed, but airway circulation normal.
Circulation is normal.
Normal.
Suppose this patient develops acute hypotension. How do you manage?
Initial fluid bolus followed by
initial fluid, then noradrenaline. Third one will be
steroids.
Steroid has a role in this type of patients. Why steroids are indicated? Acute adrenal suppression, either due to the tuberculosis or HIV itself can produce adrenalitis. Okay. So this type of patients, if they develop hypotension, steroids has to have a upper hand. Okay. Instead of starting all other drugs, initially itself we can give steroids. Okay. So that is normal. Then next is.
Next will be treatment of the infection part.
Infection anyway is that somebody is treating, but sodium.
Sodium, SIADs will start on 12. Initially we can start on 3% saline, sir. Oral correction, oral sodium, sir. Then if the oral sodium correction is not improving, the sodium is not improving, we can start on.
The first is fluid restriction. Okay, this patient does not have hypotension. This patient does not have fluid depletion. First thing is you give a fluid restriction. If it is not getting corrected, then next is diuretics. Classics, furosemide can be given. Third one will be tolvaptan. What is the action of tolvaptan?
Tolvaptan will cause the stoppage of urine sodium, which will induce increase in serum osmolality and serum sodium.
Okay, so tolvaptan can retain sodium through the kidneys. Where else it can be used? Which other condition it is cardiac?
Cardiac failure.
Cardiac failure. This is one of the newer drugs which can be tried in cardiac failure, tolvaptan. Okay, so that has got a same action of classics. Only thing is it retains
Sodium.
sodium. Okay, so tolvaptan can be started. Then what happened to the sodium?
Sodium values began to improve after tolvaptan has been initiated, sir.
Okay.
It reached up to 130.
Okay, how much 3% saline you have to give for this patient?
Initially, initially started with 100
How
ml.
do you calculate?
So sodium can be calculated by the formula from initial sodium with the sodium value which we need. So we'll minus the so we'll get a desired minus initial sodium into body weight into 0.6.
In female and male it is 0.5. That is, what is this 0.6 and 0.5? What is that? Why we are 0.6 and 0.5?
Total body water, sir. Body water.
60% of body water is 60% of body weight is water in female and male and 50% in female. Okay, so that we have to calculate and we have to find out what is the amount of sodium deficient in this patient and we have to correct it. Okay, so sodium has to be corrected first. Second thing is you are suspecting an infection or TB. Okay, we don't know exactly whether it is TB reactivated, fungus, infection. So you have to give a cocktail of therapy because we are not getting any answer for this. How do you manage? You are suspecting a meningitis, which may be partially treated, and there is a high chance of tuberculosis because that is also partially treated. How do you manage all these things?
So initially this patient had elevated LFT also, sir. So we stopped the TB ATT drugs, sir.
Okay.
Suggestive of drug-induced liver failure.
Okay.
And we started on.
How do you manage liver failure in a patient who is receiving ATT?
We'll be stopping the hepatotoxic ATT medications, except ethambutol will be stopping the HR, H and R will be stopping, HR and pyrazinamide will be.
Isoniazid pyrazinamide will be stopped. We start on ethambutol and then.
So there is a guideline given by WHO. You have to read that. You have to stop all the drugs. Ideally, you have to stop all the drugs and rule out conditions which can produce liver damage in that patient other than the drugs. Okay, suppose the patient is having hepatitis B or C, that is a reason. It is not the TB bacteria. Okay, sorry, it is not the TB drug. Okay, so anyway, you stop all the drugs and restart, which is the most hepatotoxic drug. What is the most least hepatotoxic drug? Which is the least hepatotoxic? Ethambutol can be started. Then
Rifampicin.
streptomycin also can be started. Then one more drug.
Rifampicin.
Rifampicin is hepatotoxic. So how do you manage? Because we don't know. This is a multiple episodes of TB is already there. So you are starting streptomycin and ethambutol. Okay, then what do you do? Rifampicin, how much dose?
150 mg.
Percentage? 25% of the dose of the rifampicin can be started. Wait for 2-3 days. Do the LFT. If LFT is not increasing, then increase the dose to 50%. Again, repeat the same 75%, 100%. Like that, you can increase. But what are the drugs, ATT drugs, which act in the inflamed meninges? Which are the commonly used anti-tubercular drugs in meningitis? One is streptomycin. Second,
Ethambutol.
ethambutol have lesser action. INH, streptomycin and pyrazinamide. These are the drugs which has got maximum effect. Other drugs will definitely act, but these are the drugs will have maximum effect. So that can be started. Okay. How do you start, in a patient who is having, this is a patient of retrovirus, that's why I'm asking. If patient is diagnosed with TB, if you don't start TB drugs and start ART first, antiretroviral drugs first, what would happen to the patient?
Patient's immunity will be low and the TB will flare up, sir.
What is that condition called as?
Inflammatory iris.
Iris. What is iris?
Immune reconstitution inflammatory syndrome.
Immune reconstitution syndrome. Okay, so that we should avoid that. So all the opportunistic infection, including tuberculosis, should be treated first. Treated means we don't need to wait for the 6 months. Okay, at least 2 weeks to 2 months we have to wait, depending on the clinical scenario. So here we are starting drugs to prevent hyponatremia. That is already started. TB drugs which is stopped from outside, we have to reintroduce the TB treatment, which we avoid some drugs which can produce liver damage. Then what is the third problem? She has got a meningitis. We don't know whether it is tubercular meningitis or partially treated bacterial meningitis. So what antibiotic you start for that? Ceftriaxone. Can these drugs like rifampicin cover meningitis? What is the action of rifampicin on other bacteria?
Rifampicin has action.
Rifampicin acts on most of the gram-negative organs. It acts, but it is not a very good drug. But when you are giving anti-tubercular drugs, it itself can cover most of the infections. Okay, but even then we have to start ceftriaxone or something to cover gram-negative organism in this patient. What is the dose of ceftriaxone in meningitis?
2 gram. You have to.
Yesterday only we discussed.
50 right now 100 mg.
It is 75 to 100 milligram per kg body weight. That much we have to give. Okay. Only problem is the high dose of ceftriaxone can produce. It is that comes under seizure potential drugs. Okay. Very high dose itself can sometimes induce seizures, but clinically they are not very relevant. We can start high dose of ceftriaxone. But what else you are suspecting? Here fungus can be there. Some other organism can be there. You are starting Bactrim DS injections or Colibitor, that is Bactrim DS.
PCP pneumonia.
PCP pneumonia. Okay. How do you give that? What are the side effects of that drug?
So this cotrimoxazole, trimethoprim can cause hepatorenal toxicity, sir.
Okay, it can produce renal toxicity, hepatotoxicity.
So we have to look for the creatine clearance and modify the dose.
What is the creatine here?
Creatine was normal, sir.
Okay. Any vitamin deficiency it can produce?
Vitamin B.
There are common problems. Folic acid. So it's a anti-folate drug. So we have to give folic acid along with this. Okay. Any other problem this patient is having? Fundus.
Fundus was showing was perivascular whitish discoloration size to CME retinitis.
Okay. How do you manage that?
So for that we had to start on. We initially started the patient on injection ganciclovir.
Either ganciclovir or ganciclovir. Both can be given. Ganciclovir is injection. Other one is oral tablet. How long you have to give?
That for 8 weeks.
Okay, so you have to give a long time, and after that you have to give for prophylaxis also. What is the CD4 count of this patient?
CD4 count was less than 50, sir.
Okay, so almost all opportunistic infections are very common at this CD4 count. So you will have to give prophylaxis. How long you have to give prophylaxis? Emergency medicine does not require this question. How long you have to give prophylaxis in if the CD4 count is less than 50 for fungus? What is this? CMV retinitis, PCP pneumonia?
More than 2 years, sir. 100 per year.
So till the CD4 count more than 200 for 6 months, you have to give the prophylaxis. Okay, so that takes a longer period. Every year CD4 will increase only by 100. So we have to be very careful when you are starting these drugs. It's a long duration treatment. Okay, what else? Any other problems this patient is having? Echo is normal, ECG is normal.
Echo ECG normal, sir.
Okay, what do you look in as echo? What all things you can?
Endocarditis can be there, sir.
Endocarditis echo will not pick up, no?
Vegetation, sir.
Vegetations can be there. Okay. Then
other complications, cardiac complication including cardiac failure, cardiomyopathy.
Cardiomyopathy and pericardial efficiency are two important problems this type of patients can have. That is not there. X-ray shows bilateral infiltrates. Then is the patient is able to walk?
No, sir.
Okay.
Bedridden patient. Then other things we have to look forward into oral thrush, oral candidiasis.
That was there.
Or candidiasis was not there, sir.
Okay.
Then any cutaneous dermatological problems. Yeah.
What is progressive multifocal encephalopathy?
This
Medicine PG should know. Emergency medicine, it is not required. Progressive multifocal leukoencephalopathy. It is one of the presentation of HIV patients. Like they have dementia, weakness, spinal cord like problems, like they are unable to walk. Okay, it's a progressive disorder. Only can be reversed by antiretroviral therapy. So that is one of the problem these patients can have. So did we give steroids in this patient?
patient was not started on steroids, sir.
Okay. What is the indication for steroids in HIV patient?
If hypotension, we can start on steroids, or if the
PCP?
PCP also we can
PCP
start.
also we have to give steroids. Okay. Anything else you want to add?
Then we can also, patient can also have psychiatric problems like depression, mania also can occur in HIV patients, sir.
So will you start any drug on this patient?
No, sir, even
Why?
our patient was
No, if the patient develops psychiatric depression, will you start any drug on this patient? If you want, what drug you start? What is the problem this patient is having? Huh? What is the problem?
drug induced liver failure,
Electrolyte imbalance. Which electrolyte imbalance is there?
hyponatremia.
Hyponatremia is there. Most of these antidepressants can have develop hyponatremia. Tell me one antidepressant will not have that problem that we can use in all these patients. What is that drug? Escitalopram. Escitalopram will not have much arrhythmias, much hyponatremias. Comparing with other drugs, okay, that also can have arrhythmias and this one. But it is a safer drug in elderly individual, hyponatremic patients, all these things. Okay.
Okay.
Anything else? Nothing.
Then GI complications like diarrhea also can occur, sir.
Okay.
Herpes simplex viral infections.
What is the difference of herpes simplex in a normal person and HIV patient? What is the difference?
Disseminated herpes.
Disseminated. Okay. Multi-dermatomal herpes simplex is very common in HIV patients, but whereas in a normal adult, normal elderly individual, single dermatomal herpes simplex is common. Diarrhea is there?
Diarrhea was patient was fine, sir.
Okay. What is the importance of stool AFB in diarrhea?
Stool.
AFB, acid fast bacilli. There are a lot of non-tubercular organisms can produce diarrhea in HIV patients. So acid fast bacilli can be positive in stools in many HIV patients. That doesn't mean that they are infected with tuberculosis. So we have to treat again with Bactrim DS, that is the drug of choice. Okay.